I'm John Kellum. I'm from Pittsburgh. This is my disclosure slide. I don't think I'm going to actually speak about, I may speak about some fluids here, maybe. Other than that, I don't think so. Okay, so what's new in sepsis for 2018? Well, this actually came out in 2016 and got a lot of press in 2017, but I think it's still worth discussing in 2018 because I think that we're still trying to get our head around exactly what all of this means. So the key features of the Sepsis 3, and I find this very interesting because as people talk about it around the world, I think there's still some confusion about what's different about this definition compared to what was true prior to the Sepsis 3. And the truth be told, there's not a lot different, but the few differences that are here are actually pretty important. So first of all, severe sepsis is gone. We talk about infection, and we talk about sepsis. And sepsis is when infection causes organ dysfunction. We define organ dysfunction not by the amount of organ dysfunction, but by the change in organ dysfunction from baseline. And that's extremely important because the problem before was that people would say, oh, you just need some SOFA points. Well, the problem with the SOFA score is that for respiratory, for renal, for cerebral, for liver, you can have SOFA points for chronic disease. So if you have a baseline creatinine of 2, you already have organ dysfunction. And then if you have, I don't know, a cellulitis of your pinky, you somehow have sepsis and you could get enrolled in a trial. And that's clearly not what was intended, but it caused a lot of confusion. So this has clarified that quite a bit by saying you actually have to have new organ failure defined by 2 or greater points of SOFA. Now, SOFA is still imperfect, and it would have been nice if the consensus group would have come up with something new to define changes in organ function. But nevertheless, I think that's an advantage. Patients with septic shock are those patients that have sepsis who have a failure to respond to fluid resuscitation, adequate fluid resuscitation, without really defining exactly what that is. There have been some post hoc efforts to try to define adequacy of fluid resuscitation, and they're largely misguided, which I'll talk to you about in a minute. So the group here wisely stayed away from trying to define adequate fluid resuscitation, or suggested that the other way to get the definition of septic shock is to have an elevated lactate level. Now, I will say this is not really discussed in the paper, but I think we have to also acknowledge that that's very context specific, right? So if I run up the stairs 12 times just to get up here to the lecture hall, I will increase my lactate concentration. And if I have an infection, I might actually increase my lactate concentration even more, and that doesn't mean that I have septic shock. So there's always a little bit of a need to put these things in context. And I mention that importantly because, for example, I recently took care of a patient who had a COPD exacerbation, and the patient was in respiratory failure using accessory muscles and needed to be intubated. The patient was intubated, but along with all of this sepsis bundle care, a lactate was sent, and the lactate was 4. And the argument was made that this patient has sepsis. And, well, the patient doesn't have infection. Oh, the patient has infection. Where's the evidence for infection? Oh, well, the patient's got respiratory failure. He's a COPD exacerbation. The lactate came back down very quickly once the patient was intubated because the patient wasn't using accessory muscles to breathe. So anyway, you have to put this into appropriate context. Bottom line is you need to be a doctor. The final line here is bizarre, suggesting that the mortality rate associated with septic shock is 40%. As I'll show you in a minute, using these definitions, mortality rates, hospital mortality rates, are actually about half of that. But nevertheless, this is what was written in the paper. All right, the next thing that was suggested is that you could identify, and this is where confusion exists as well. What the authors are suggesting is that you could identify, you could screen people for being at risk for sepsis by just looking at 3 variables. Now, this has been misinterpreted as that's the definition of sepsis. That's not the definition of sepsis. The definition of sepsis was what I showed you a moment ago. This is a way of identifying patients who are high risk for sepsis. And you can identify them from having these 3 criteria: elevated respiratory rate, altered mental status, and a low systolic blood pressure. And if you have 2 of those 3, you are at increased risk, obviously, for having sepsis. If 1 of 3, you are still at increased risk relative to having 0 of 3, and obviously 3 out of 3 you have. Now, none of those things are specific at all for sepsis, but they're sensitive for identifying patients that have high risk for sepsis. What about treatment? Again, this is a paper from a couple of years ago, but it's still quite germane. This is the study we did looking at early goal-directed therapy. There was no benefit to giving early goal-directed therapy relative to standard of care, sort of physician-guided resuscitation, or another protocol which was designed to deliver fluid without as much of the bells and whistles associated with early goal-directed therapy. And you can see there's no difference. 60-day mortality, which was the primary endpoint, or 1-year mortality. This was replicated by the ARISE trial, which was done in Australia. You can see that the Kaplan-Meier's are again superimposed, as well as the PROMISE trial that was done in the UK. Now, amazingly, the New England Journal accepted our meta-analysis of 3 superimposed Kaplan-Meier curves, and you meta-analyze them together, and you generate another superimposed. Well, you know, it's a way to get a paper in the New England, I guess. So yeah, this shouldn't have surprised anyone, but in fact, these trials, when you add them all together, are superimposable. In fact, interestingly, the I-index for this, the I-squared statistic for this meta-analysis is 0. So these are highly, highly homogeneous comparable studies. It surprises me that there are still people that argue that there's a place for early goal-directed therapy. If there's a place for early goal-directed therapy, it certainly isn't in the hospital, at least not the hospitals that we practice in. Just in case you're interested, we also looked at a bunch of pre-specified subgroup analyses, and you can see that there is really just no heterogeneity at all across these things, across these different areas. You could argue, well, look, liver dysfunction patients actually do better with usual care. Well, it's a very low end. Look, respiratory patients, failure patients do better with early goal-directed therapy. Again, it's a very small end. I think those are just statistical flukes. There's really no difference across any of the subgroups of patients. And this goes on to the next slide. Now, looking a little closer at the study that we did, we had 3 groups of 3 strata, 3 interventions. They were 3 interventionary groups. Protocolized standard therapy, which was a protocol that didn't involve giving inotropes or blood products, but just involved titrating fluids to blood pressure and CVP, which was actually designed to give the most fluid and achieve that early goal-directed therapy, the next amount of fluid, and then usual care. The interesting thing about this is that physicians left to their own devices give less fluid overall compared to what they would give if they were following one of these protocols. The reason I mention that is that not only is there no difference in survival, as I've already showed you, but in fact, the reason that you give fluid resuscitation is to prevent cardiovascular collapse. And if anything, the group that had, it's not quite statistically significant, but you should be concerned by the fact that the group that got the most fluid actually had the highest risk of having secondary cardiovascular failure. And for the kidney, the same thing is true. There was actually more dialysis in the first week in the group that got the most fluid. Now, to be fair, we've analyzed this signal further by looking at all sorts of other ways of looking at kidney injury, and there isn't any signal of harm associated with the protocolized standard care, the group that got the most fluid, but there's no benefit either. So what I would interpret this to say is that clinicians are actually the ones that should be judging how much fluid. Now, Marlise is going to talk to you about Surviving Sepsis Campaign guidelines, and in the U.S., we've actually put these into law in certain areas where people are forced to give fluid boluses to patients. And these studies, if anything, suggest that what you really should be doing is relying on physicians to use their judgment as to how much fluid. And I feel it's a gross bastardization of these results to assume that you should give fluids by cookbook, because this study actually shows just the opposite. So the problem, of course, that we have is that our treatments for ICU therapy or ICU therapies are largely based on giving fluids, and I think it's only been recently that we've begun to be concerned about the fact that giving too much fluid might be just as bad as giving not enough fluid. And giving just the right amount of fluid is what we should be focused on. Now, of course, deciding how to give just the right amount of fluid can be a bit challenging. And this, of course, reminds me of, I've showed you this before. All right, so there is evidence of toxicity from fluids. This was seen probably best in a trial that I think probably didn't get enough attention in the critical care community. This was done in pediatrics, but it was also done in Africa. These were patients with sepsis where probably the majority of patients had, 2/3 of the patients had malarial sepsis, but a good third also had other forms of sepsis, including just garden variety bacterial sepsis. And what was seen was that the group that got fluid boluses, whether it was albumin or saline, actually had the worst outcome compared to the group that got no fluid boluses. In the United States, as I mentioned, there have been laws passed in New York State, for example, where physicians are compelled to give the bundle of therapy that involves early antibiotics and fluids. And the compliance with those laws have been looked at relative to outcome. And as you can see here, the delay in achieving the sepsis bundle, which is essentially fluids and antibiotics, has been associated with worse outcomes. So this is hospital mortality, and this is the delay in implementation of the bundle. And you might say, well, that proves that you should give the bundle. But if you dissect the bundle out, you find that the entire effect is seen from giving antibiotics. Fluids have no effect. Clinicians left to their own devices titrate fluids in a way that doesn't seem to at all confirm to this giving a fluid bolus early, and that doesn't seem to impact mortality at all. Whereas if physicians delay antibiotics, that does impact mortality. So what should you do to treat sepsis? You should use antibiotics. What should you do with fluids? Use your judgment. That's what the data shows. Now, you might argue that the type of fluid matters as well, and there have been several studies that have shown this recently. This is some of the best work that's been done. You've seen this presented at this conference, if you were in this track yesterday, by Andy Shaw, who's one of the investigators. But these are two trials that randomized patients or randomized the order at which patients received. These were done as pragmatic studies, so the individual patients weren't randomized. But when you give balanced fluids, whether you're in the emergency department or in the ICU, this is the ICU data, there's about a 1% absolute risk reduction in the development of major adverse kidney events, which is death, dialysis, or persistent renal dysfunction. And in the severe patients, this was largely driven by differences in the persistence of renal dysfunction. In the low-risk group, the ER patients, the effect was, again, a 1% absolute risk reduction, driven largely by the differences in persistent renal dysfunction. This actually was driven more by death. What effect does this have overall? NBC News calculated that about 50 to 70,000 fewer deaths would occur in the United States alone by just changing from traditional practice in the U.S. From saline to balanced fluids. Now, what about the underlying drivers of mortality and sepsis? Clearly, these trials have shown that patients from sepsis die because of lack of source control and proper use of antibiotics. They don't die, it seems, from lack of saline. But what else is causing? What's the pathophysiology that's well, this has been in debate for many years, largely because experimental studies, animal models, and some human work has shown that the mechanisms of sepsis are multiple, that there are multiple, there's activation of inflammatory response, of complement, of coagulation. There's the effects of cell injury on release of damage-associated molecular patterns. There's the effect of the pathogen itself and bacterial products, which are pathogen-associated molecular patterns, which can injure cells. And there are effects of treatment that we provide, including our use of mechanical ventilation, our use of antibiotics and other drugs. If you look at inflammatory mediators, it's quite clear that either mediators of inflammation or coagulation or oxidative stress are all quite tightly correlated with mortality, whether you look at patients at the time of presentation or 24 hours later. There is a strong relationship with many, if not all, of these variables and the development of mortality in these patients. Does therapy influence that? More importantly, does the type of therapy, whether it's early goal-directed therapy or protocolized standard therapy, have any effect? No, it has no effect at all. This is the changes in inflammatory mediators and coagulation and oxidative stress marker over the course of the first 24 hours, or 72 hours in patients that receive standard of care, usual care, protocolized standard care, or early goal-directed therapy. There's no impact at all. So it's not surprising, therefore, if these are the mediators, if you will, of mortality, they're not impacted by the therapy. The therapy's not impacting mortality. There is some interesting subgroup analysis, however, and this is worth bearing some note to. So I've been very negative about this idea of saying that things should be cookbook, and I stick to that. However, it is notable that the subgroup of patients that seem to benefit from protocolized therapy is not the sicker patients, but the less sick patients, by measures by IL-6 and IL-6, IL-10, for example. So less inflamed patients appear to do better with early goal-directed therapy. And although it's not quite statistically significant, the line doesn't quite get, the confidence interval still straddles 1 for the fourth and the third quartile. The point estimates are well on the other side of harm from early goal-directed therapy if you're more inflamed. Now, I'm going to interpret this in a somewhat controversial way, and it's really a hypothesis that I'm putting forth. But my hypothesis is that if the patient doesn't look very sick, maybe having a protocol to ensure that they get a reasonable amount of fluid helps. If, on the other hand, they look really sick, maybe the protocol that you're giving actually generates too much, or maybe it's not enough fluid, but maybe you calibrate fluid better for this population because you're concerned, and you don't do it very well for this group because you're not concerned. Now, that's a hypothesis. The studies that we have don't address that, but it is something to think about. Now, is there something else we can do for the group that's really inflamed? Maybe this is why steroids work, and maybe this is why we see discrepancies in the data with regard to saline. Regard to steroids. So this is the 2 steroid trials that have just been published. The adrenal trial showed no mortality benefit, shorter duration of shock, shorter duration of first mechanical ventilation, but no effect on ventilator-free days because patients had relapsed and got re-intubated. Whereas the trial in France showed a mortality benefit, more vasopressor-free days, more organ failure-free days. Vent-free days were also not statistically significant, although the trend was in the same direction. Why the difference between these 2 trials? Well, there were much sicker patients in the French trial, in the Approaches trial. 49% versus 28% placebo group mortality. Norepinephrine dose more than twice as high in the French trial compared to the Australian trial. there was earlier treatment in approaches, less than 24 hours compared to 20 hours plus or minus 90 hours. I mean, you could be in the trial and get therapy 3 days later. What's that all about? Boluses versus continuous infusion. However, it's also true that mortality difference was not robust in the approaches trial. The fragility index is 3. It's a very marginal p-value. Studies largely agree, however, on reducing shock and the duration of organ failure. I suspect that there is an impact, and it's probably increased in the sicker patients in terms of those that are more inflamed. And then finally, what is this group of patients that are most inflamed? I presented some of this yesterday. There are adults, patients with sepsis, a small subgroup, probably as much as 5%, who have genetic diseases, not polymorphisms associated with increased IL-6, but no, they have actual traits, carrier states for genetic diseases which impact the inflammatory response, diseases like macrophage activation syndrome, HUS, familial Mediterranean fever. They don't manifest the genetic disease because they're heterozygotes. But when they're stressed from sepsis, they behave as though they have these conditions and they have a cytokine storm. They're very different than the other part of the population. So in conclusion, sepsis is a life-threatening organ dysfunction caused by dysregulated immune response to infection. Early appropriate antibiotics and source control, therefore, are the most important treatment. Everything else is a distraction. No evidence of more aggressive fluid therapy reduces organ injury or improves organ recovery, including AKI and septic shock, compared to giving what the clinician believes is the right amount of fluid. Sepsis is not one disease, and there may be opportunities to treat certain subgroups of patients with an increased mortality risk. And with that, I thank you for your attention.